Greetings from the KIMS Institute for Heart and Lung Transplant. I'm Dr. Sandeep Attawar. Thoracic organ transplantation is a well-proven therapy for end-stage heart and lung disease. When patients are referred by physicians, it's generally at a time that a majority of them have a significantly diminished quality of life. They're oxygen dependent and severely reliant on caregivers for even the most basic of daily activities. It is believed that most of them would not survive for more than a few months or probably even a year without having a transplant. All of them have undergone reassessments and escalating medications, reaching almost the threshold of maximum medical therapy. And it's at this point that most of them have to turn up at our center, referred for a transplant consideration and a possible detailed evaluation. That evaluation includes disease staging, a functional assessment, and an analysis of medical conditions that we would call comorbidities, as well as an assessment of their social and their lifestyle factors. And once we determine that none of these factors would either prohibit a complex surgery as an organ transplant with acceptable risks, or would be predictive of them having an undesirable outcome after their transplant, only then would we consider their candidacy. Our heart and lung transplant program wait times are something that we are actually quite proud of. The majority of patients that are transplanted are generally within 3 months of being listed for their transplant. And this is better than and probably comparable to many of those other centers in our region. But as far as the nation goes, wait times are an average between 4 to 8 months. And I think people should come to the KIMS Institute for Heart and Lung Transplant because we have a process that understands the tailored requirements of each patient and strategizes their treatment to be able to meet those very exacting needs. Also, our outcomes are far superior than most other places. Our hospital stay after the transplant is shorter than everywhere else, and most patients would go home within 12 days of a heart transplant and approximately about 21 days following a double lung transplant. Our long-term survival after a transplant within the first year is about 95% for the hearts and 85% survival in that first year for double lungs. So this is in many ways better than what you would expect in a nation where you would compare these very same statistics with other centers. Our program has now been in existence for almost over 5 years, and during that time we've developed a highly experienced team of experts that's very well accustomed to taking care of patients needing heart and lung transplants and helping them recover from these procedures with superior outcomes. I like to think of ourselves as being more like a family, and we welcome all our transplant recipients and their caregivers into this very extended family. We all strive to be able to establish this enduring and perennial relationship between all of us, and especially since we believe that we need to know what's going on with our patients' health and their welfare. And we want them to share these fine details and nuances because I truly believe that this is exactly what provides the success to undergoing not just a successful transplant, but having great outcomes in the short, medium, and long term. Let me begin by giving you the reason you should come to KIMS Heart and Lung Transplant Institute for a transplant. I would like to call this the KIMS model of care, something which is particularly suited to great outcomes. The core of our care model is close consultation. And what I mean by that is a daily combined ICU round of every single transplant recipient. And this interaction is followed by a cross consultation between a number of different specialties during a sit-down team meeting every single day. And this team includes transplant cardiologists, surgeons, pulmonologists, infectious disease specialists, transplant intensive care, nursing and doctors, nutritionists, and rehabilitation specialists. And any potential transplant recipient has multiple limitations that are primarily caused by their failing organ and its effects on the rest of their bodies. And these are sometimes amplified, unfortunately, by disease-modifying medications that may include steroids. So pre-transplant evaluation or rehabilitation, nutritional supplementation, and physiotherapy not just play a vital role in arresting this decline, but also help immensely in building up reserve and making them better candidates to understand and withstand a tenuous operation, thereby reducing ICU stay in the post-transplant phase. A transplant evaluation done before the transplant also does help to identify and plug many modifiable gaps in a recipient's overall health, which goes a long way in their recovery and their long-term health. In the spectrum of all solid organ transplants, the challenge with the lung transplant is very unique, as this is the only organ, when transplanted, that is open to atmosphere, and this makes its aftercare even more special and even more difficult. Our negative pressure transplant isolation rooms with personalized care and strict barrier nursing, round-the-clock telesurveillance are the pillars of patient care after a transplant. Early mobilization and aggressive rehabilitation with the most up-to-date of equipment and specialized rehabilitation teams not just strengthens this phase of recovery but bolsters it in a great way. We have something that we like to call our new Organ Restoration Center for lung transplantation, which will provide a great opportunity for us to deploy ex-vivo perfusion organ models to the donor lung. The principle is called lung rejuvenation and enhancement. Here, the organ is actually supported outside the body, termed ex-vivo, on a machine that supplies it with nourishment, treats it with antibiotics, while physicians closely monitor its progress. When repaired, enhanced and assessed over a period of time and then found to be meeting those very exacting standards of a standard lung, only then can we use it for a transplant into a recipient. This is a game changer because this technology will contribute to increasing the safety margins of a transplant and also augment the number of total lung transplants performed in this country in the next 5 years by not just expanding the donor pool but also making this therapy more accessible to meet demand.
As an entrepreneur, as being the Managing Director of the Krishna Institute of Medical Sciences, and especially being a cardiac surgeon, I feel very honored by myself and the entire team. Heart and lung transplant program was much beyond my thinking, has been successful, and a lot of the patients do get a benefit out of it.
We were very fortunate to meet with Dr. Sandeep Attawar and team, and what we've been able to achieve together in the last 1 year has become a beacon of excellence, and we've also been able to set new standards in the field of medicine. We're happy to be credited as the largest heart and lung transplant program in the country. We're also one of the largest post-COVID double lung transplant programs in the world.
And while it is very painful to see someone struggling to breathe when they wait for a lung transplant, it is exhilarating to accomplish a successful transplant. What is even more gratifying is to be able to see them at the time when they leave the hospital breathing like a normal person. And that spark of happiness and that satisfaction is what gets me going every single day, every time. And this is the motivation that is enough for us as a team that promises to be relentless in the pursuit of perfection.
Hello everyone, this is our Ex-vivo lung perfusion machine. The Ex-vivo is lung perfusion is used since our donor pool is small, so increase the donor lung utilization. Ideally, only 10 to 20% of the donor lungs are utilized. So rest are discarded because they don't meet the ideal lung condition. So this machine helps us increase the donor pool, help us evaluate and recondition the donor lung, and helps us increase the marginal donor lung to a good lung. So EVLP, this machine has multiple parts. This is our organ chamber box, which is kept on a table, which can measure, we can do an X-ray, and it has a weighing scale on it. So next is the steen solution. Then we have lung cannula set. One is will be to the LA, which has a LA cuff suturing set, which has pressure lines on it. And then second one is the PA cannula, which also has a pressure. So next, once we take the donor lung, LA cuff has to be sutured and the PA is sutured. Then the cannulas are given to the by the perfusion team.
The solution is drained from LA with the help of an LA cannula, which comes into the reservoir. From reservoir, the solution is pumped to the oxygenator with the help of a centrifugal pump. From oxygenator, it is pumped back into the PA with the help of this PA cannula. So basically, our priming is done with 2 liters of steen solution, 300 international units of heparin, and an antibiotic and a methylprednisolone of 500 mg. The priming is done at 25 degrees Celsius. We de-air the complete circuit and circulate it at 25 degrees Celsius. The steen solution, it is made up of Dextran 40 and human serum albumin. This helps in providing optimal colloidal oncotic pressure, and also it aids in prolonged assessment period. The oxygenator is flowed through a dry gas. The dry gas consists of 6% of oxygen, 8% of CO2 and 86% of nitrogen, which can be analyzed with a gas analyzer. The main purpose of this dry gas is to deoxygenate the solution. Our circuit consists of various sensors. This is a temperature sensor, this is the pH sensor, this is the CO2 sensor, this is the oxygen sensor, and we have one more oxygen sensor in the PA line too. And these two oxygen sensors will be giving the delta PO2. The sensor values can be measured with the help of these kind of optical fibers, which goes to the transmitters and is displayed in this monitor. The value of each sensor is recorded here with a particular time interval and also is represented through a graphical representation. So the first sensor here shows the LaPO2 here, which is recorded here. The PaPO2 is recorded in another sensor and its value is displayed here. The CO2 is also measured through a different sensor and the value is displayed here. And the pH sensor, the value is displayed here. So all the sensors, they will be monitoring the levels at a particular time interval, which is often represented with the help of a graphical representation. Our target flow is 40% of donor's cardiac output. We initiate with 10% of target flow at 25 degrees Celsius, which is gradually increased to 40% of cardiac output, and a temperature of 37 degrees Celsius with a time interval of 10 minutes. At 32 degrees Celsius, the sweep is initiated with 1 liters per minute. Meanwhile, the ventilation is also initiated. Any excess volume in the organ chamber is sucked into the reservoir with the help of the suction pump. Regarding pressure, LA pressure is maintained between 3 to 5 and PA pressure is maintained within a range of 15 mmHg. To maintain the normal range of 3 to 5 LA pressure, we adjust the reservoir level so that LA pressure of 3 to 5 is maintained and adequate drainage is aided.
Myself, Uruj Abbas Hassanabad Sayyed. Okay, I am 42 years old and I am a lung transplant patient. Okay, and before this transplant, it was very difficult for me to survive. 10 liter oxygen was there, और उसमें भी ऐसा था कि I can't go to the bathroom also even. I can't walk because if I am walking, so cough is coming and the breathlessness is there.
The important fact to note is that in a country like India, where 2 or 3 lakh patients require a lung transplant annually, probably not more than 1,000 donations happen every year. It's a scientific fact that 70 to 80% of all lung donors are deemed unsuitable or borderline. So when your yield is only going to be 20 to 30% of all the donated lungs, every single organ is important. Every single organ on offer is vital to save a life.
Patients who are going to be there in the waiting list, they don't have to think what is going to be happen. They have to trust onto the doctors, and the now modern technologies are there.
For lung transplantation, we have standard acceptable out of the body times of between 8 to maximum of 10 hours. What the organ care methodology with Ex-vivo does is, it allows us to stop the watch exactly at the point when the organ is put on the Ex-vivo platform. Ex-vivo basically is an organ care system, and the word itself describes what it does. Ex-vivo is out of the body. So you're improving its performance, and then performing a transplant, you have not just a better outcome, you also have saved an organ from being discarded, and obviously that is the best optimum way of maximum organ utilization.
It's very good overall कि जो पहले की मतलब लाइफ थी मेरी और अभी की लाइफ है, it's not totally change. Okay, I can feel more relaxed, more happy कि I can walk. I am not on the oxygen first of all. Okay, I can go to my work so that I can feed my family actually.
As we go through the passage of time, we realize that this very single one stable platform can allow us to deploy multiple therapies, including immune cloaking. We could actually even go ahead and change the blood type of the donor organ. Now, this is a remarkable advance in technology and in human science. If you have this technology available, you can make every single organ on offer an O organ, and you could transplant it. I think Ex-vivo truly is a game changer in the field of lung transplantation.
I did my post-graduation in Sweden, and I can see Ex-vivo is a perfect reflection of Swedish society, especially in transplantations. There are a lot of products from Ex-vivo. Advancement they have done in this field is extraordinary, and I feel great privilege to be representing them in India.
The KIMS Heart and Lung Transplant Institute runs one of Asia's largest thoracic transplant program. Their transplant team is working at the cutting edge of technology. They have added MyTransplant, a comprehensive digital platform to transform their key processes. MyTransplant is a next-generation digital tool driven by data and AI. Transplant decisions are complex and difficult. Take the case of a typical pre-transplant workup. Sifting through a mountain of data for a go, no-go decision is a difficult task. There are tons of blood workup, radiology scans, fitness tests, psychosocial evaluations, clearances, and treatments advised. A large transplant center makes many of these life-impacting decisions multiple times, week after week. Managing all this manually with ad hoc tools lead to errors and lapses. At KIMS, however, the MyTransplant system has solved the problem. MyTransplant app helps by organizing the reports in a usable, accessible order, highlighting the missing reports, incomplete tests, comorbidities, and the trends in the critical parameters for the patient. Automation of transplant decision process has brought in a great deal of discipline. The observations recorded during the review meetings are readily available at the 11th hour when the organ is retrieved, and every second counts. Success of a transplant depends a great deal on the immediate post-op recovery in the ICU. The conventional ICU data are recorded on paper charts. This takes away precious nursing time into data logging. Paper data are static. Highs and lows in critical parameters need to be manually monitored, and doctors need to be alerted. KIMS Transplant Center has a vision of implementing a complete eICU through MyTransplant. In the eICU driven by MyTransplant, patient parameters would get automatically captured, tracked, and displayed in an actionable format. Doctors would get a view of the ICU data via the MyTransplant mobile app from anywhere. Infections is the biggest killer in thoracic transplant patients. A real-time analysis of ICU data through novel algorithms for predicting early warning signs of infection is the next goal. MyTransplant is a technology with heart. Listen to Anita Kulkarni Puranik, founder of MetaMagics that created MyTransplant.
My name is Anita Kulkarni Puranik. I started MetaMagics in 2008, and in 2009 my husband was diagnosed of liver cirrhosis. Finally in 2014 we got an organ for him in Apollo, Hyderabad. Then post his transplant he had some complications wherein the doctor wanted to know a particular parameter, how has it behaving, before his transplant and now. And I just pulled out my laptop and showed him this is what it is. And he was amazed. He said, how did you give me that answer, because I didn't see you flipping through papers or anything. So then I told him that I have a tool, and I've been kind of using it as an ad hoc, a makeshift tool for my husband's managing data. So far I was only looking at it from the patient side of it. Now I started looking at it, the whole organ transplant space, from the doctor's side of it, from the administrator's side of it. And every time it's about life, and you have a very short window of time to respond to critical situations.
At KIMS, MyTransplant has filled a big gap in care continuity. Listen in to what Dr. Sandeep Attawar has to say about this.
Solid thoracic organ transplantation is a new and rapidly growing field, a science that requires unparalleled support from hospital infrastructure, clinical expertise to big data resource. It is noteworthy that at the Krishna Institute of Medical Sciences in Hyderabad, while spreading our network across the span of this large nation, it necessitated an electronic health record pivot that not just allowed longitudinal follow-up and cloud-based patient care data resource, because it needed to be instantly accessible on a mobile phone at the flick of a switch. the trends in drug level testing, biopsy data recall, serial bronchoscopy findings, and many other novel additions to digital surveillance have allowed us to set new standards for the KIMS Heart and Lung program. Building our mHealth program with My Transplant has empowered our treating physicians while simultaneously building patient trust and elevating long-term care of post-transplant patients to near perfection. Metamagics has proven to be our valued digital partner, aligning and striving to fulfill our vision of transplant care and transformation. I applaud the team at Metamagics for their stellar contribution in helping build Asia's first fully integrated and most prolific heart and lung transplant network. Thank you.